Good morning, one and all. So, can I start? Yeah, this is HPV surgery department grant round. We are going to present. I will start with two cases of hepatocellular carcinoma, which the patients undergone a liver resection, extended resections, major liver resections. I'm going to describe this two clinical cases as snapshot, followed by the data regarding the SCC and liver resection, along with SCC and the portal vein thrombosis and liver resection. Then subsequently the hepatocellular carcinoma liver transplantation is going to discussed. So I will start with the cases. Two cases I am going to present. The first one, along with the video of the intrahepatic intraoperative videos, I am going to show. So this is first case, a 63-year-old gentleman with pain of right upper quadrant pain since last three to 4 years. Has been evaluated outside with USG showing multiple space occupying lesions in the liver. CCT abdomen reveals the lesion occupying in the segment 5, 6, 7 and 8 with a large tumor 11.9 cross 13 cross 11.9 cross 9 centimeter. Along with that there is another lesion in the segment 4. The features as per the imaging are suggestive of hepatocellular carcinoma. So he came to ILBS. PET scan revealed the large tumor along with query adrenal metastasis. However, that was not accessible, and we went ahead with the plan of surgery, and we investigated the patient. These are the investigations. Alpha fetoprotein and PIPCA both were quite raised, and as you can see, I will stop here. Considering the large tumor in the right lobe of the liver, the remnants were the left lateral remnant was 320. However, the tumor free volume, as you can see, is 478 cc. Hence, essentially, the remnant liver is approximately 67%. I will show you the PET CT followed by CT imaging. So this is the PET CT report. The plan was the patient was planned for, since it's a large hepatocellular carcinoma. Test, yeah, yes sir. The background liver was chronic liver disease was present, but it was not cirrhotic, sir. On evaluation plate. So CBC and LFT has been done. Albumin was, I will go back. Albumin is 2.94, sir. Fibroscan is 287. Chronic hepatitis, features of chronic hepatitis. Yes, sir. Upper GI endoscopy was done. It was normal, sir. However, the fibroscan score revealed the score is high, suggesting fibrosis. So, since the lesion was occupying most of the liver, the remnant parenchyma, which is functional, that was 478, and the remnant which we are going to save with anticipated surgery of right extended hepatectomy, it was almost 67%. That is the reason we went ahead with the plan of TACE followed by surgery. So this is we started with staging laparoscopy, and this is the CT PET scan film of the patient. The tumor is occupying most of the right lobe. As you can see, one lesion. This one is in the segment 4. This is the not contiguous adjacent lesion. So we planned for right extended hepatectomy. This is hilar dissection of the right side. This is the right posterior portal vein which has been delineated. The hepatic veins, I would like to say, since it's a large tumor, it was very close to the diaphragm. In this case, in this such kind of cases, sometimes we go for anterior approach hepatectomy. in which we don't mobilize the liver from the right side initially, because that has got its own risk in terms of tumor settling and the recurrence risk. So it has been shown that anterior approach is more beneficial in such kind of patients. So we went for first. Yes, sir. Yes, I am just going to quickly review it. So this is the transaction line which is just adjacent to the falciform ligament. This transaction line is between the right middle hepatic vein and left hepatic vein. This transaction line. So essentially, we are removing segment 5, 6, 7, 8, and most of the part of the segment 4. This is the transaction line and the starting of the parenchymal transaction. As you can see, most of the parenchymal transaction has been done. This is the middle hepatic vein, and along with the segment 4, along with the segment 4 lesion would be lying here, and that has been resected along with the specimen. So this is the last part of parenchymal transaction. As you can see, this is the bile duct. First we are going to divide the bile duct, followed by vascular resection. This is right anterior hepatic duct division. He has got a portal venous anatomy of type C. This is right anterior portal vein. Subsequently, the right posterior portal vein was divided and the stumps were overshown. This is the portal venous stump. As you can see, there was two stumps of right anterior and right posterior portal vein. So the liver has been completely transected. The inflow has been taken out. Followed by the caudate lobe division. This is the last part of the parenchymal transection from the caudate lobe. Now we will see the right hepatic vein, and the liver is being mobilized from the IVC. This is the right hepatic vein, which is being clamped and divided, and the stump is overshown. Since the inflow and outflow has been occluded, now the liver can be handled. Since it's a large tumor, to minimize the chance of tumor seeding, we go for anterior approach. That is not the conventional approach for liver resection for hepatocellular carcinoma. Conventionally, we would mobilize this right lobe of the liver, followed by inflow and outflow tackling. So this was adherent to the diaphragm. In this case, it's better to resect the part of the diaphragm. However, without any diaphragmatic resection, this could be resected. So as you can see, the liver here is the remaining liver. This is the specimen with a large tumor. The remaining liver is left lateral and very small segment of 4B which is remaining. So histopathology revealed grade 2 hepatocellular carcinoma, size 13 cross 15 centimeter, and tumor is confined to the liver, and all the resection margins were free of tumor, and there was no large vessel invasion and small vessel invasion, which is good for the patient. and surrounding liver parenchyma, as you can see, and there was a periportal fibrosis as we expected in this patient. This patient was a chronic hepatitis B. So he was treated before being taken off for liver resection. So this is the first case, and the second case I am going to 50-year-old gentleman with presentation with pain abdomen. USG revealed SOL liver, which was occupying the most of the left lobe and part of the right anterior lobe. CT scan revealed a large tumor, 10 cross 7 centimeter encapsulated exophytic soft tissue density lesion in the right lobe. However, it was involving the segment 4 too. On subsequent imaging, we got that. Hypervascular, the tumor was hypervascular with features suggestive of SCC with portal venous washout. There was hypodense area and necrotic area at the center of the tumor. This is the CT scan. As you can see, it involves also the segment 4 along with right anterior segment. He underwent PET scan and which revealed the same tumor involving the central part of the central part of the liver, that is segment 4 and right anterior segment. The PIPCA and alpha fetoprotein were highly raised. Viral markers, HBs antigen was positive. He was HBV DNA log 5. He was treated with antiviral along with the lenvatinib. Subsequently, the patient was planned for surgery. Before that, we since it's a large tumor, we went for TACE. This were the preoperative workup. Here, liver was comparatively looking normal with albumin level of 4.2. Alpha fetoprotein and PIPCA both got reduced after TACE. So, since this tumor was occupying the central portion, the right posterior volume and the left lateral volume was inadequate. We planned for parenchymal preserving central hepatectomy, which is from liver resection point of view a difficult task, but obviously this helps in saving a lot of parenchyma of segment of either right posterior or left lateral. So in such cases we usually try to first delineate the right posterior and left lateral inflow pedicles, so that we are safe in terms of the remnant. Then we also delineate the right anterior pedicle if possible at the hilum, otherwise we keep it for last. We can divide that during last part of the parenchymal transaction. We start with yeah yeah this is going to be followed by data. Yes, ma'am. Point taken. This is going to be followed by data by Dr. Nilesh. He is coming over. I'm just going to finish it in another 2 minutes. Yeah, and we are going to going to follow it with the data about SCC and liver resection and SCC and liver transplantation too. So we start with resection. These are all very daunting resections, which I think we should all be well versed with. This we start with left side resection with close to the falciform ligament in case of central hepatectomy, and followed by the resection of the right side of the liver, which is essentially this transaction line is between right posterior segment and right anterior segment. So we are going to remove right anterior and segment 4 completely. So I'll just skip this part.
What we would be interested is how we decide what surgery, how much resection, those things will be important. What surgery we plan, what are the challenges anticipated. That should also come up.
So that's exactly what he has shown, that this is a central tumor sitting in the right into the center of the liver. Central hepatectomy, one of the major actually procedures in the liver, has shown why we are doing parenchymal preserving. Then he has shown the data on also on preoperative hepatitis B positive log 5. We waited, treated the hepatitis B. We also did a TACE so that the tumor, while we are waiting, tumor doesn't progress. So all this is shown. है ना?
So this
all सब बताया ना उसने अभी तक.
This is the right anterior segment pedicle. and we have preserved the right posterior segment pedicle. So as I said, we try to divide right anterior segment pedicle during the transaction just to safeguard the posterior pedicle. The whole idea is to save right posterior segment from parenchymal preserving surgery point of view. So this is right anterior segment, right anterior pedicle, which is being clamped and divided. And in this case would be both right posterior and left lateral segment. So this is the right part of the transaction surface. These are small veins. This is the segment 4. I would like to show this part. This is the middle hepatic vein, which is the main drainage of the central area of the liver, which is right anterior segment and the segment 4. As you can see, the tumor has been resected with a very good margin, and we have been able to save both the right. This is the right posterior pedicle, right posterior segment with this is the pedicle for the right anterior part of the liver. This is the left lateral, and this is cholangiogram followed by resection, which shows the right posterior pedicle and some of the anterior pedicle maybe all has been saved, and the left lateral is portion is saved. So this is essentially this is parenchymal preserving surgery, which should be aimed whenever there is a doubt regarding remnant of the liver. So this presentation would be followed by data regarding the SCC and liver resection by Dr. Nilesh.